let you keep your Medicare card. And then also you'll get a new card that says, Blue Cross Blue Shield Medicare Advantage, right? So they still put the Medicare on there. So it can be very confusing where you find out that at some point your senior parent was at the doctor's office and the doctor offered a Advantage plan through his practice. Or somebody sent them something in the mail and they signed the paper and they flipped from their Medicare to a replacement plan, okay? Do you guys understand how those plans work?
I have a question because I was told that I needed a supplement.
Supplement, so supplement is different than a
and
replacement.
And then I got an Advantage plan.
Right, so, can I use your board?
Sure.
Okay.
It added to my Medicare.
Right.
Because Medicare only pays
But
for
that
80% or
Does that
something.
have to be a private supplement? Because I was told I can't get a supplement because of being through the state.
Yeah, so it just depends on your unique situation, and this is what makes it so complicated.
Also, find the next seminars, I'm gonna find someone to speak about this.
So
Yeah.
it also can be very confusing because usually if you're working with an insurance agent, they are incentivized to move you off of your Medicare onto an Advantage plan, okay? So that I feel is a conflict of interest. So my overarching recommendation is if you qualify for Medicare and you have an underlying condition, right, a chronic condition, where our trajectory is that we're gonna eventually need some extra support, whether that be in a rehab, whether that be in long-term care, or whether that be at home, the traditional Medicare is going to give you the best coverage, okay? Now, if you're over 65 and super healthy, have minimal pharmaceuticals, you go to the doctor a couple times a year, those Advantage plans can be really helpful in saving in our premiums, right? But if you are over the age, I always say 75, and have an underlying condition or a chronic diagnosis, you should always hold on to your Medicare.
But it's too late once you become that age and have a problem.
Right,
And have underlying condition.
So if you can hold on to it, hold on to it. If you have the finances to supplement, right? We were talking about some supplements. So I'm gonna do this.
That's what I thought it was called.
So Medicare,
You have to have it.
and this comes directly from the federal government, okay? And we've paid into that during our younger years, okay? So essentially the way you can look at it is you have a medical bank account with the federal government that you've been putting deposits in throughout your life, right? So we've got money up here.
That's only if you worked, correct?
No, you can still qualify for Medicare.
You can qualify through your spouse?
Through your spouse.
Yeah, I did because I worked there.
Yep, so when you hit 65, you qualify for federal Medicare. Obviously your premium will fluctuate based on your work history, based on obviously a bunch of different conditions, on how much your premium is going to be for that plan, but every American that's over the age of 65 can qualify for Medicare, okay? So we have a lump of money up here, right? And then we also have to add a premium to it. That's our contribution into that pot. What happens is we have all these benefits, right? Those are those benefits. When you decide to opt out of your Medicare, either by choice or by dictation of a employer or a pension or retirement, you'll go down to a replacement or an Advantage plan. Okay? So what happens when you sign those documents? The federal government takes the money in your bank account, your federal bank account, and sends it down to this company, right? So this could be Blue Cross Blue Shield, this could be Humana, this could be Aetna, it could be United Healthcare, right? So these companies are all for-profit companies, right? They make money, they're not nonprofits. The first thing that they're gonna do when they get that money is they're gonna take a piece of it for themselves, right? That's their revenue. So we might have started with $10,000 up here, just for argument's sake. They're gonna take a profit that reduces the bank account down to $1,500. So when we reduce the funding, we have to reduce the benefits, right? So we had 1, 2, 3, 4, 5 benefits up here. Maybe we only have 4 down here. And that's when you'll start to see co-pays and co-insurance for your services to make up the difference, because we've lost part of the funding. That's why I always tell people, hold on to this, right? We don't want our bank account, our medical bank account, to be diminished because of profit, right? So, and then, if you do have the extra finances, we have supplements, right? So you can buy all the supplements you want. And I tell people all the time, if you can afford a long-term supplement, long-term care supplement, buy one. I know that they have pharmaceutical supplements. Buy one. If you need a cancer supplement, buy one. If you have the finances to do so, right? And you can do this even if you have this plan as a primary or this plan as a primary.
Why would they tell you can't then?
You can. You may not be able to because of your unique situation.
different.
So again, a lot of people of older generation, pensions and retirements were a big part of your work culture, right? Where we were working and paying into our pension, and that was our retirement plan. Unfortunately, the pension and the retirement management get to decide what they're going to do and what they're not going to do.
Are these special supplements? I mean, are there private supplements?
Yeah, these are private supplements. So you can call Blue Cross Blue Shield today after we leave and say, I'd like to know what supplements you have available. I'm 65 years old. I have a history of cancer in my family. I'd like to know how much a long-term care supplement plan would cost. And you can just pay that premium privately on your own. So that would be your secondary. So when you have a supplement, whatever Medicare or your primary Medicare Advantage plan doesn't pay, it then gets kicked to the supplement plan and then to you.
I don't know. I was told that you can't do that or you lose your benefits.
Oh, no, you can't.
No. Yeah,
So
you-
like in nursing homes, so someone who goes into a nursing home, the way it works is Medicare pays 100% for
100
the
days.
first,
Yeah.
100 days.
well, they pay 100% for the first 20 days.
Yeah.
And then day 21 to 100, it's 80% Medicare, 20% supplement insurance. So if someone does not have supplement insurance in a nursing home,
You
come
get
day
20%.
21, they're paying 20%, which is typically about $225 a day.
A day. Right.
So,
Yeah, it is.
you know,
It
so
is.
that supplement insurance actually is beneficial with
Right.
helping offset.
The cost that you may get.
Okay, so I'm talking to you. I don't know
Within
who-
regards to your plan,
Right.
I would call and find out if you can get a
Who would
supplement.
I call?
So who's your
United
pension
Health.
through?
She said
United-
UHC.
Well, there was a speaker from United Healthcare that told us this. This was a couple of years ago.
I would call UHC and
I would
ask.
call UHC, and then also you say you get that through your retirement, correct? Do you guys have a retirement manager
Teachers.
or a pension holder that?
Yeah, it's a teacher's.
Yeah, so I would call the teachers
Teacher
union.
retirement system.
Yeah, I would call that entity.
Maybe you get rid
We're gonna teach back that. Yeah.
Yeah,
Any,
I'm not sure. I'm on United
Yeah.
Healthcare too. I have long-term care insurance though, and that's separate.
You have what?
long-term care.
Long-term care.
Oh, yeah. that I know would be-
But that's that's separate.
That's a separate-
Yeah, that's a
So
supplement.
if you could do that one, I would.
So again, you just have to, I think the key with this stuff, and again, I know Christina said that she'll probably schedule a time where you can spend a whole session just on this topic, because it is.
Sorry,
No,
sorry.
that's
You're
okay.
fine. No.
It's very complex and it's very complicated to understand.
I'm going through it right now.
It's so hard.
I was just gonna say, you
It's so
should
hard.
be talking to 65-year-olds.
Yeah, so I know
No, you almost,
60-year-olds.
no, yeah, you almost need to talk to like a 60-year-old, someone
Right.
pre.
Yeah.
Right, and I had
Medicare,
to, I
because
might,
Yeah,
it's so
it's confusing.
confusing.
So
You
I
get
had
no help
to-
when you go, they just say sign up.
Yep.
Yeah.
Yep,
Well, and like Corey said, those reps for these advantage and replacement plans, they're incentivized.
They're incentivized,
They want
right?
you
I know,
to
I know.
pick a
I've
plan
learned
because
since.
they're making
Yeah.
a percentage off of that.
So
They
they're-
want
That's
you.
why we get so much mail in
Yep.
October and November.
What are you
and
talking-
right,
November.
open enrollment.
Oh,
I
this is much
AARP
better.
coming to my house.
Yeah.
Yeah.
So
already.
very tempting to go with the medical
coming to your
advantage
house
because the
already.
premiums are so low.
And that's how they get you. So that's the thing, is they'll dangle the carrot, like, oh my gosh, I could save you $200 a month.
Go ahead.
But the catch-22 on that, and this is where I need to empower you, is when they say, oh, I'm gonna save you X, Y, and Z on your premium, your response to them would be fantastic. What am I losing?
Because you're healthy then.
What am I losing, right? Nothing is for free. A lot of my older seniors are like, oh, I saved on my premium and I have the same benefits. Nothing's for free. So if you're saving on your premiums, you're losing somewhere else. It's just whether or not you have the knowledge to ask, where am I actually losing? Okay? And they're going to recoup that in your 20%. You know, they're going to cut how many days they cover if you need to go into
Been hit with all
rehab.
that already.
Right? So just be mindful of that and the intention of who you're talking to. My intention is always to make sure that my patients and our families have all of the information so they can make informed decisions that make sense, right?
See, what they do now with ours is that you do have a choice. I think they said every year now, Sandy, you can change. But I have underlying conditions, so I've read that a lot of times it would be so expensive for them to take you, they won't take you.
And I actually had to do this with my grandma recently. My grandpa unknowingly opted both of themselves out of Medicare and onto a Humana plan. The Humana plan was not going to work with her and what she required in that stage. And yes, it is expensive to reverse that machine and get back to traditional. It can be done, but in extreme cases. You know, if you're already well into that process, sounds like you are, if any of you other ladies are well into that process, I would again reassess your finances, look at what coverage you have under the Advantage plan, and see where you need to fill in, right? So that we can plan for the future. So, yep. Any other quick questions about that? And then I'll move on. That's okay. That's okay. I'm glad that it was brought up and that I could obviously plant the seed, just so you guys know going out into the community when you're talking about these things. So I don't want you to be duped. I don't want you to be taken advantage of. I want you to understand what's happening in the background, so that you can ask the right questions and make good decisions for yourselves and for your spouses or for your older senior parents, okay? So again, in regards to coverage for home health, Medicare is going to cover home health at 100%. Your Medicare replacements are obviously going to be contingent on the plan. There may be co-pays or co-insurance or deductibles that need to be met. If you have Medicaid only, unfortunately Medicaid is a state-funded program. They do not have a lot of coverage for home health. They will cover some nursing, they'll cover some therapy, but very short term. And unfortunately, there's not a whole lot of agencies that work in that space just because we don't get paid enough to compensate to send our staff to the home. So
I do have a resource on that.
yes,
though, so.
I have one.
I have
one
locally out here.
Yeah, so if you have somebody who's Medicaid only, it's not like they don't have options, it's just that it does narrow the scope on what they can ask for or who they get to work with. So our industry, our company is actually owned by Humana. We're the largest provider in home health and hospice in the country, and we do not work in the Medicaid space at all, okay? So in regards to what would qualify you for home health, when you should ask your doctor for home health, so in regards to what scenarios you would need extra support. Anytime you go to the hospital and have to go to rehab, whether this be for yourself, your spouse, or a parent, or a sibling, anytime you have somebody who's in formal rehab, they must come home with home health, okay? Most social workers are going to put that into their care plan, but just so you know, that is one of the largest indicators that home health is needed in the home, and you should get an order with the discharge of home health coming out of rehab. Anytime you go to the hospital, if you go to the ER or you have a short-term stay at the hospital, whether that be for a fall, an orthopedic procedure, an exacerbation in a diagnosis, whether it be CHF, COPD, diabetes, whether they add a new treatment protocol, whether that be the addition of oxygen, you should be asking for home health, okay? In regards to clinic, right, when we're seeing our doctors, A lot of our patients, and I'm not sure why, it might be just a lack of knowledge or knowing what they're allowed to have, do not ask their doctors for home health. They will usually wait until there's an emergency, right, where we're going to the hospital, before we understand that maybe there are some struggles. So I encourage you to be open and honest with your doctors so that they can make those referrals and recommendations early on instead of waiting until we have a crisis, okay? So if anybody you know, anybody that you take care of, or your personal self, if you're having challenges understanding your medication, if you're having issues with stumbling and falling in your home, if you're having issues with dizziness, if you're recognizing that your endurance has decreased and you're not feeling as strong, those are all early indications that we need to bring home health in. And the sooner we get into the home, the greater the chances that we can prevent any major medical crisis where we would need to go to the hospital or to rehab. So early intervention is key with home health. So any questions on what you should be watching for, or?
Can the doctor say, no, you don't need that, I want you to come to see me?
They can. And sometimes you may not meet the criteria for home health, so your doctor may say, hey, can we go to outpatient, right? Let's go to outpatient therapy. But again, if you meet that criteria that we talked about early on, you know, where we're meeting that homebound status, you can always say, you know what, I'm not comfortable going to outpatient, right? Physically, I'm not comfortable going to outpatient, or I don't have transportation, you know, I would prefer to do it at home. Most physicians that I've worked with over the last 8.5 years will always honor that, as long as we're within the regulation of home health. So feel free to talk to your doctors about that. Again, most doctors, their patients just don't mention that they're having challenges because they're afraid of what's going to happen. I encourage you to be open so that the doctor can go ahead and get those early interventions for you. So, any questions about qualifications for home health?
You had listed issues falling and
Yeah.
something about medication.
Yeah,
In addition to medication?
Sure. So here are some of the larger indications that would require home health, okay? So medication management. So this is if your doctor has prescribed something and you're not sure what you're supposed to be doing, or you're not taking your meds the way you should be taking them. You require additional education. If you have all kinds of pharmaceuticals, we know now that our doctors don't get to spend very much time with us, right? It's maybe 5-10 minutes in and out, right? If you have complex medications, you need more time, right? Like what is this medication for? Why am I taking it? How frequently do I need to take it?
What happens if I don't take
Right,
it?
what happens if I don't take it? Are there gonna be any adverse side effects? You know, is there gonna be an adverse side effect with another pharmaceutical that I'm taking? You know, is there a proper way to take it? Is there an improper way to take it? So what our nurses do in regards to medication management, when they come to the house, they'll do something called a medication reconciliation. So they're gonna ask you to pull out all your bottles, all your ointments, anything that has been prescribed, anything that is a supplement that you take, and we're gonna go through each and every one, right? So that you have a real understanding, or the patient has a real understanding, or the caregiver has a real understanding of what each medication is for, what it's going to do, and why we need to be compliant with that medication. The nurses are awesome at this because they'll actually look at everything and say, wait a second, you shouldn't be on this one and this one. Or these two could interact with each other. And again, unfortunately, our doctors don't usually do a really good job in regards to collaboration. So we have our primary, maybe we have a cardiologist, maybe we have a pulmonologist, you know, we're seeing all these different specialists and they're ordering all this stuff and nobody's really communicating and closing the circle. So medication management is really crucial when we start talking about multiple pharmaceuticals, or if you're just having a hard time managing them, right? So the nurse will do all of the medication management. Anytime that we have any dizziness, oops, my marker's not working. Dizziness or vertigo, okay? So anytime you're having the symptom of dizziness or you've been diagnosed with vertigo, that's another huge indication that you probably will need some home health. Again, as long as you meet the criteria of being homebound and clinically necessary. There's a whole lot that we can do from a therapy perspective. There's a pamphlet that I put on the stack there. It says Safe Strides. That's actually a Medicare-based program that we developed with the federal government, specifically around dizziness and fall prevention, okay? So there's a bunch of unique therapies that address the inner ear.
I'm sorry, would you repeat that, because I do have vertigo.
You do have vertigo. I feel horrible for you. I've had little bouts of it throughout the years, and it is not enjoyable. So anytime you have a vertigo diagnosis, that would be clinically necessary for home health therapy. On the table, there's a pamphlet called Safe Strides. That is our fall prevention program, specifically designed for people who have a balance issue, right? Do you guys understand balance as a whole, or do you want me to kind of go into that real quick?
Go into it.
Okay, so we're gonna take a time out on our list. So, balance. There are 4 systems that we utilize to stay balanced, okay? Obviously, the first one is our musculoskeletal system, and this little list is in that pamphlet. So we have our musculoskeletal. And that's the one that most people focus on, right? If I'm strong enough, if my bones are healthy, I can stand up and stay balanced, right? When we engage in therapy, most physical therapy is going to focus on that system, right? We're going to do leg exercises, we're going to do core exercises, under the notion that if you stay physically strong, you shouldn't fall. Unfortunately, that's not true. And that's why we did the research and developed this program. We also utilize our vision, right, to stay balanced. So we're looking, our brain is taking intake in through our eyes and assessing how level we are and how we are in relation to the space that we're viewing. Most of our seniors will have some deficiency here. We don't claim that we can fix that, okay? So if we have degeneration or blindness, we won't say that we can come in and help you with that. However, you can utilize the other 3 systems to compensate for any vision loss, to minimize the risk of fall, okay? We also use our vestibular system. Does anybody know what the vestibular system is? Inner ear, right? It's this tiny, tiny little organ inside your ear with little crystals that actually manages a large portion of your balance. Our sweet girl in the back with vertigo probably knows this too well. When those crystals get out of alignment, it can cause you to be unsteady and make the room spin. Most elderly citizens, elderly people, have a low functioning vestibular system, okay? And the system is a use it or lose it system. So as we age, we tend to get more rigid in our neck, right? We're not turning our head as much, whether we have an orthopedic issue, aches and pains. We're not out driving as much. Usually as we age, you'll start to see that people will become very rigid in the upper body, whether they're using a walker or a cane. They're not doing this motion very much. The motion, turning your head side to side and looking up and down, activates the inner ear. So if we stop doing that movement, essentially the inner ear will stop functioning. When the inner ear stops functioning and we turn our head or tip our head down, the room will start to spin, right? Because we're turning that system back on. Within 2 to 3 weeks, with the proper therapy, because there is very unique therapy for the inner ear, we're going to force that system to turn back on over and over and over again. And eventually that spinning sensation will go away.
You know, when you hear a funny story, sometimes when I'm in church, I do that, and I think people must think I'm crazy.
Yeah, but that's all it takes. But that's all it takes. All it takes is turn your head side to side and looking up and down, and that will keep the inner ear active and healthy.
That's why I witness the fitness.
Yep. Yep. And then
It does work on that every Friday.
Yep. So she's working out your inner ear. The last one is your sensory system. So somatic sensory system is how do we, the data that's brought into the body through our touch, right? If we touch something with our hand, how do our feet feel on the floor? A lot of our diabetic patients will have neuropathy, right? So they can't feel the floor. Our brain isn't getting the intel or the information it needs to keep us upright. So all 4 of these systems are very crucial to balance. The only one that we can't fix is vision. However, with proper therapy, which Safe Strides is exclusively for fall prevention, you're gonna get all the therapies for each of these systems, okay? So anybody who has balance problems, has a history of fall, you should be calling me and asking for Safe Strides.
Which Safe Strides is unique to Kindred.
It is only
and Kindred
Kindred.
only.
And it
Put
is,
that out there.
yeah, and another caveat, it is a Medicare program. So Medicare patients only can have this program. Medicare recognizes the program and allows us an extended period of time to work with the patient to get the awesome results that we can get from that program, okay? So if you're on an Advantage plan, you can't have Safe Strides.
Oh.
But this person also has to be homebound, correct?
Yes.
Okay.
So they have to, again, homebound doesn't mean you can't leave the home,
Yeah.
okay? You're allowed to leave the home to go to the doctor. You're allowed to leave the home to go to church. You're allowed to leave the home to go to the barber or to the beauty salon. You can go out for lunch if family comes in, family wants to take you out for lunch, you can do that. It just needs to be, if you're going to bingo every week, you're not homebound. Okay,
So
so,
if you're going to church service,
No,
or
church
no,
is
not
fine.
church service,
Church is fine.
the Friday exercise group,
yeah,
probably not homebound.
not homebound. So if you're seeking, if you're able to seek social activities outside the home, the federal government's gonna say, well, you're well enough then to go to outpatient, right? So that's just the kicker, the distinguisher there. Also in regards to, we'll jump back to this list of things to watch for. So falls, that's another indication. Decreased stamina or weakness. Right? Fracture. Post-op care, right? If we have to go in for a procedure, whether it be orthopedic or surgery of another nature, where maybe we're gonna have a surgical site with a wound, you can always have home health, right? Even if it's just for a week or two. That's the great thing about home health. You can have us for a week just to help you, 2 weeks to help you, or we have patients that are on home health for 6 months, right? So average care time for home health.
You can erase any of that.
Oh, okay. I didn't think I'd be using your board, I apologize.
Well, I didn't mean your stuff, I meant our stuff.
Oh, sorry.
Don't worry, I have all that in my brain anyway.
30 to 60 days.
You're very visual.
Okay. I'm a visual learner too.
Yeah.
So-
I'm a visual learner.
On average, a patient will be on home health for 30 to 60 days, okay? Some patients will fall less than that. Like I said, if maybe we had a procedure, like our orthopedic patients are usually on for 2 weeks, and then they go to outpatient. So if you have to have a hip done or a knee done, the nurse and the therapy team will come see you for a couple weeks, get that incision site healed up, and then send you to outpatient for the rest of your therapy. We also have patients who end up staying on home health for months and months and months. The indication there is once you're on home health, we have to reassess you every 30 days. Are you still homebound? And are we able to prove incremental improvement? So this is kind of where I'm going to segue over to Christina. When we get to a point in care where we can't show an incremental improvement in your medical status, the insurance companies and Medicare will say, discontinue home health, right? So we have to show even the smallest bit of improvement to keep the services active, right? So there is a point with our patients where we get to the point where home health no longer is able to prove that legally, and we have to say, okay, home health has been exhausted, and that's when we start talking about transitioning to hospice. Okay? Any other questions for me before Christina brings you guys over to the hospice
Is
presentation?
this only in this area?
All across the country. We cover 42 states.
Yeah,
Yep.
we're nationwide. Kindred's nationwide.
So, and I can help with anybody. So again, if you have elderly parents, yourself, siblings, friends, anybody that you're caregiving for, whether they're here locally or across the country, I can help with setting up care for them. I have, as of date, worked with patients in 12 different states. So it is an easy transition, especially if you're bringing somebody to live with you or you're moving somebody to live with somebody else. We could follow the patients pretty much all over the country.
I actually am currently working with a social worker at University of Chicago. Patient lives here in Illinois but wants to be transitioned to Indianapolis to be exact. And that is the best part because, you know, it's a different time zone, like different payers.
Any other quick questions before I let Christina take over?
So you are like a private company then, you have nothing to do with pathways or?
No, they're
Private, yeah.
all of the presenters are just, they're people I've known in the industry for years. They're people I have worked with, and they're good, you know, good resources for people to have, for you guys to have.
And I'll leave my cards as well. So if anybody goes home over the next few days or next few weeks, you think about something that you need an answer on or clarity on, I'm available via email, text, or via phone. I was just telling her I work 7 days a week, so don't feel bad calling me in the evenings or on the weekends. So I just want to make sure if you guys have specific concerns or specific situations going on that we can talk through those. But
One other thing. I'm sorry, but I'm really into this.
That's okay.
It's good information to have.
Just a suggestion, because I've been through a lot. Under medications, I found out, I've been to my doctor, and I had knee surgery, my last surgery was knee surgery, May 12th, and they put me on blood thinners and some other type of medicine. Well, I went to my doctor in this February, and they still had on my medication chart Zolrato, blood thinner, and a bunch of other stuff, which I no longer take, all kinds of pain pills and stuff. And so the next time I told them to take that off my records, and I had told them that before. So I assumed it was off my records. Well, I went into the website and looked at my lab reports, because I just recently got that set up. And it's all still on there.
Yep, and our nurses, our clinical team has to be in direct communication with your doctor. So whoever's writing the order or prescribing home health will be in constant communication with our team. So if that type of stuff comes up in the home, our nurses are gonna call and speak directly with the physician and say, hey, this is not correct. This is what you're showing in the chart. This is what's actually here at the house. You know, do we need to remove these, or do I need to place an order at the pharmacy? Should this be something? So there's going to be continuous conversation between the clinical team on our side to the doctor, okay? So they will be getting firsthand report from our clinical team and what we're seeing, what we're observing while working with you or a loved one of yours. So that does help. Again, unfortunately, the doctors just sometimes miss stuff. They're super busy. They have to see a ton of patients every day. So this way they have a double check with our team, double checking all that stuff. Any other questions?
I would like to know where you were 5 years ago.
Yeah, right.
I was in
10, 15 years ago.
Well, no, I went to the Social Security office twice before I applied for Social Security. And they said, well, you'll get A automatically, B, you're gonna pay a premium, and if you want drug insurance, it's gonna cost. And I said, okay, well, I don't take a lot of drugs. I said, I don't need that. Well, now I'm penalized because I didn't take it.
Yes, me too.
You know, and it irks me that they didn't say it's required.
Right.
You know, and I said, well, I had insurance because I stupidly took Medicare out, even though I was still working. So Medicare was my supplement for my regular insurance, and I paid like, I don't know, 8 months of Medicare in premiums. But yet now I'm still being penalized, and I'll be penalized for the rest of my life.
For the rest of your life.
And it's like, why didn't somebody tell me this? I went there twice, and they never said it's required.
They don't.
So
And the
Give
thing
them a
that
chance.
bothers me is these commercials. Why aren't you guys commercializing? Say, don't take Medicare.
I try.
Yeah, I was gonna
I
say,
cover
I'm
a lot
always
of-
like, please do
Yep.
not take those. Nope.
Yep,
they are
I cover a
ripped off,
lot
like-
of ground. So answer your question, 5 years ago, I was in rural Missouri, working with families, doing the same role in rural Missouri. But again, that's why I want to empower you and empower as many people as I can, where my motivation is to make sure that you're taken care of. right? And that's gonna look different for each person. However, I've worked with thousands of patients at this point, and almost all of them would have benefited from having their Medicare in their later years. Okay, I would say 9 times out of 10, that's usually the situation. That would have been the best situation. Again, I like to give people the benefit of the doubt. They probably don't understand it themselves, right? So they're just giving you this quick, generic answer, like, okay, yeah, do this, do that, without really understanding the scope of the decision that you're making and the long-term consequence that it's going to have down the road.
Well, and realistically, you have to think we specialize in our field. Those people specialized in their field.
Right.
So they don't know really what that Medicare replacement policy looks like when that person needs skilled nursing, needs home health, needs hospice, needs whatever it may be. They don't know that. And unless they've actually personally go through it with a family member, they don't know. I know what it looks like because I've worked in home health. I've worked in hospice. I've worked in assisted living, and I've worked in skilled nursing. So I know what that looks like.
So my recommendation, 5 years too late,
Sorry.
would be specifically for you, if there's a way for you to get back with the penalties, because I know that those can be.
I have Humana as my drug.
They just purchased us. Can we just say that?
Yeah, we are owned by Humana, so
We're peons to them.
Because they were the most economic. See, I thought if I don't need it, why should I pay for it?
That's how I felt.
And it's like now I'm penalized because I was trying to save the government money.
right.
Yep.
Well, you're not.
Of my money. Well, I was trying to save my money.
Yeah.
But
Me too.
the thing that gets me is they don't tell you it's required.
Yeah.
No.
You have
You
to
know.
carry. You
And
have
was
to
that
carry it.
because of Obamacare?
No, as far as I know, that's kind of how it's always been. You know that you have to accept the full offering.
And it would be taken out of your, Social
Mhm.
Security.
Yep.
And how much do you need?
Right. Again, it's all in or all out, which it makes it a little bit more complicated because it's like, okay, I want to come out and I don't need that right now. It's kind of like at 65, you need to make a decision for the next 15, 25 years,
Yep.
right? And they don't explain, don't explain to you that once you say, I don't need that yet, I'm going to opt out, you're not allowed to come back in. Well, you can, but we're going to charge you,
Yeah,
right?
I guess
So
that's why isn't Medicare saying, hey, if these commercial, these actors that they're getting, it's like they're paying them a big mega bucks.
Exactly.
Shame on them.
Yeah.
Shame on them.
It's
Joe
about money.
Montana, Dick
Yep.
Buckton, I'm like,
They don't even need their Medicare. They
and I'm
don't.
like, and you're doing this
Right.
to Americans.
Yep.
It's like,
Yeah.
In my opinion, and this is the waters have gotten even muckier in recent years because now they allow doctors to sell their own advantage plans, right? So their doctor can say, "Oh, my practice has its own advantage plan, and I'm gonna say you have to have my advantage plan for you to be my patient." Right?
There's assisted living.
So there's assisted
also
living who offer
do
their
it.
own plan. So they're now allowing care providers to get into the insurance business, which is a
Bad
huge
mistake.
conflict of interest in my opinion. The hospitals also want you on these advantage plans because Humana, Blue Cross Blue Shield, United Healthcare will pay them more when you're at the hospital, but once you walk out those doors, oh well,
Advocate has theirs.
Yep.
Their advocate plan.
Yep, so most of the hospital systems are in the insurance business, most doctors are in the insurance.
Hospitals non-profit.
No, that's big business, very big business. You're talking big with a B, very big. So they are now selling their own insurance. Doctors are selling their own insurance. And again, it gets very convoluted when you have somebody who's supposed to be looking out for your interests, whether that be the hospital, your doctor, rep from the insurance company. And at the end of the day, this will always be the motivation, right?
Well, at the end of the day, I'm paying a premium. I'm going to get my money's worth. I feel dizzy. My vision is
Yes.
bad. My foot has problems.
Yes.
Hey,
Why not? And that's the mentality.
you know, they're making big money.
Yep.
And
Advocate.
it's, you know, it just,
Advocate.
where
And
are
that's
the Dr. Welbys anymore?
very few and far between.
They like
But-
their money.
But a lot of physicians will wait until you end up over at the hospital, right?
Bless you.
Where we're having,
Which we
we're
don't even have
having,
our own doctor.
right, where we're having
right.
little issues, right? Where we can shrug it off, like, oh, that's not a big deal.
Well,
I'm
it's a big deal
fine.
now that I talked to you.
I know.
Man,
This is available.
my knee hurts.
Right.
My
So
knee hurts.
don't wait until you're having a major issue, right? This is there for the taking. Like you said, I love that theory. You've already paid for this, right? You're entitled, as long as you meet the criteria, you are entitled to this care as much as you need it over the rest of your life. And trust me, the hospitals would love people like you, because more than chances are not that you're not going to have a major crisis where you're going to end up at the hospital and then need to go to rehab. And trust me, that is far more expensive, right? So use it. Advocate with your doctors, advocate for the people under your care, advocate for your spouses, advocate for your parents, and say, every time, if there's an issue, can I have home health for this? Even if it's for a few weeks. I want home health for that. Can you send the nurse out? Or I want therapy at home, you know? I don't feel a lot like going out during COVID. A lot of people didn't want to go to an outpatient gym, right? I want to do it at home. I have every right to say I want to do it at home. So use that information and feel empowered when you're speaking with your provider, okay? Any other questions?
Is that true for medical advantage too?
What's that?
Is that true for medical advantage?
Absolutely.
Need some
You might have your,
medication.
you have to have your 20%,
Your 20%.
Yeah, that's,
but you
that's
again,
okay, I saved on the premiums.
there you go. You saved on your premium so you can pay your
I'm on
copays.
my
I
medication.
pay when I need it.
Yep. Any other questions? I know that Christina still has. Yeah.
When you're 65 and
I'm
you're
trying
starting
to
your
find a
Medicare, you
holistic
take the
doctor.
medication portion,
Mhm.
and you think, I really don't need it, but I'm gonna get it. As you get older and you need more medication, the price doesn't go up.
I don't believe that the premiums will change on that. It's not contingent on how many pharmaceuticals you have.
Okay, so
So
you
as
get
far as
older-
I know, I'm not an
Okay.
expert on, I think that's part F. Is
I
that
don't know.
I think the
have-
pharmacy or the medication is part F, if I'm not mistaken. Our services are under part A. Again, your part B is your outpatient doctor's visits. I'm not familiar with, in great detail, the pharmaceutical piece.
Okay,
But my understanding is once you're in, you're in. And that doesn't change regardless of if you start with one medication and 10 years from now you have 15 medications.
yeah, that's what I
Mhm.
wanted.
So-
So
Do
two card.
dentists ever do this kind of thing with insurance? Because where I go, they have a plan where you pay $365, they say, for their medical plan. And then you get 2 free cleanings and 20% off any major type work or, you know.
It might be, so I know like when I go to the eye doctor, I have vision insurance through my husband's insurance, but they only pay for glasses or contacts and one exam a year, but the glasses and contacts, it's once every 2 years. So I actually have a plan, like I buy the, what is it, America's Best, whatever the, what's the plan, Mom? It's like 3 years for so much money and you get, you know, discount. It's just a little bit extra to help me save a little bit money because my plan is, you know, once every 2 years to get contacts and glasses, and Lord knows.
I mean, I'm sure if you guys wanted a dental presentation, I could.
You hook us up?
Yeah.
That would be a good one.
My dad works in the dental finance industry, so I know lots of dentists.
See?
Lots of dentists.
We all know people at some point.
So where they can kind of go over that sector of the coverage, the dental
I mean, do
sector.
you think that's like you were talking about, a doctor having his own insurance, or is that just something to?
I mean, dentistry is a whole different beast when it comes to coverage because it's so minimal. You know what I mean? Where we're not talking. A normal patient's only going to go to the dentist twice a year, right? We may have some procedures, small procedures, whether it be a filling or a crown or
Yeah,
a
but
bridge.
as you get older.
Right, you get more and more. Yep. So I don't know. Again, I'm not an expert in that part of coverage, especially if it ties to Medicare, the dental side. I would have to obviously find you a resource for that. But anything else related to home health?
We just don't want to take much
I
of
know.
your guys' time.
I already took an hour.
Yeah, way to go, Corey.
I was only supposed to get a half hour, ladies.
To be honest with you, I don't want to take much of you guys' time. I like that you guys are actually asking questions. So to segue in from her, so The typical home health patient is 30 to 60 days. So with that being said, did you guys actually know that the typical hospice patient is 38 to 105 days on services?
Nope.
When you guys think of hospice, what do you guys think of? End of life? Passing tomorrow, passing in a week. Like I said, the national average in 2020 was 38 to 105 days on services. So I put some stuff on your guys' desks. There's a lot of information, so I didn't want to kind of overwhelm your brains. Hospice does not mean end of life, passing tomorrow. There's a lot of different services that come with hospice. Like Corey had mentioned, when someone is going through home health and they're not making those strides to get better, it's probably time to maybe start looking into different services and geared towards hospice. Their team is fantastic. We actually are on calls with them on a weekly basis to kind of see which patients they've had on services that are declining, not necessarily improving the way they should, and maybe we get our nurse to come out and do a consult. You guys have every right, so I know we were cracking jokes about Kindred and Safe Strides only being unique to Kindred. With that being said, hospital systems have their own home health and hospices. They will push those on you. At no point do you have to go with them. Each company is different. Each company will provide a different, I always say interview. Go interview people. Social workers at hospitals will say, who would you like? We'll set you up with Payless, or we'll set you up with an advocate. If you guys had a friend who had a different service and they had a really good experience, be like, no, I want this one, which I think it helps companies like us who are freestanding from hospital systems, because the level of customer service we're going to provide is a lot better than what the hospital system is. My mom had her surgery and she goes, there's a nurse coming out, and I said, ugh, the advocate. Like, ugh. Just because I know she had surgery, she had an open wound, they're going to be sending out a nurse. That's just typical. I knew they were going to do a med rec with her, all of that stuff. I knew. Again, that was, that's her business and she's going to take care of it. And I'm okay with that.
Come on.
Here's the things, I knew it was going to be a lupa. I wasn't going to give it to you guys. So I want you guys to know that, okay? So don't ever feel
patient choice.
Yes.
Just so you know, that's what it's
patient
called.
choice.
Patient choice.
You guys are your own advocates,
Yeah, but
and
sometimes the patient choice, you're a little way.
it's
Yeah,
also,
so
but
you
it's
know,
also
yeah.
family choice at that
Family
point.
choice.
Oh yeah,
So
for
can
sure.
I giving that to your
Can I
daughter?
I'm gonna do a caveat, sorry, I'm taking all the time, caveat on hospital-based home health and hospice systems, okay? So I think the point that Christina is probably gonna make here, but I wanna hammer this home. The hospital systems have an endless stream of patients, right? They're coming in, they're sending them out to their home health, they're sending them out to their hospice. So it doesn't matter, right? It doesn't matter if they keep you on care as long as they possibly can under the law. It doesn't matter if they give you the best care that you deserve in your home, because there's 3 other patients coming out of the ER tonight that are gonna take your spot. Okay, so my recommendation, I don't mind if you don't use Kindred. Interview them and use a provider that isn't tied to the hospital system, because the driving force behind that service is the revenue. Get them on service, get them off service. Get them on service, get them off service. Who cares what the outcome is, right? We're scored, publicly scored. Go ahead.
Can I ask a question?
Yeah.
This was really important to me when it was happening, and I just got a flash of it. We had home health care for my husband, and immediately it went from he needed drugs 3 times a week.
Ivy.
Yeah, and he had a port. And after the first session, they started talking to me about me having to
Teaching
do
you.
that.
Yeah.
Is that
Yes.
are they different?
No.
That's
so,
normal.
okay, that's a good question. Okay.
What is the question?
So she's talking about in-home IVs.
Uh-huh.
Okay, she had IVs for her husband. This also is applicable for wound care. So say the doctor orders IVs 3 times a week. Well, we'll say every day. We'll say everyday IV push, right? Within the regulations of home health, you have to have a teachable caregiver, whether that be yourself, a spouse, a sibling, a hired caregiver, who's going to be taught how to manage that port and administer the IV push. We cannot do daily visits. If you need daily clinical supervision, you do not qualify for home health. You should be in a nursing facility, okay? So if you need that kind of support, you have to go to a higher level of care, so that would be a subacute rehab. That's why when you were taking care of your husband, our nurse is going to teach you how to manage that, and then obviously she'll decrease her visits to supervise the IV administration, but we can't stay and do the administration every time.
So that's why they wouldn't send him home at the end for hospice, because he was on drugs or something?
No, so we do, hospice is different. Hospice is actually, we can do daily visits.
Yes. So was he still coming home with home health before you made your transition to hospice?
He was, he did have home health and then he ended up, I don't know.
So I will tell you,
don't know,
most-
but they told me that he had to go directly to a facility.
Okay.
He couldn't come
Most
home.
hospices don't usually do
Drips.
drips. I will tell you that in the home.
Because that's considered an intervention.
So maybe
It's a
that's why he
intervention,
couldn't
so
come
I know that
Yeah.
I don't
So,
think
like,
we do
Yeah, so
IV
like
on hospice.
hospice will do an antibiotic orally, but we won't do drips.
And you guys don't do fluids either, right?
We will send them to the ER,
For
yes,
IV fluids.
for IV fluids. If someone has, if they need fluids, we'll send them to the ER, do an observation stay, and then get them back same
So
day.
it sounds like maybe you were transitioning from hospice where you were doing an intervention, the IV intervention. And then when you go on to hospice, usually that's discontinued. So, but again, for IV and wound care, so say you need a bandage change every day, the nurse is not gonna come every day, right? We're there to monitor and support and educate, whether that be yourself or your caregiver, to manage that wound site. Again, if you do require everyday care, that's nursing facility, right? So we have to go to a facility for that
So
care.
not a hospice nurse can do it?
So if the person is on
Hospice.
hospice, okay, transition back to hospice. So again, like home health, you have to qualify for hospice, right? So in the paperwork, I have what's referred to as my eligibility wheel. I feel like my mom has heard me talk about all of this stuff. There's your eligibility wheel.
Yeah, I see.
There's actually a bigger version it's a 8.5 by 11.
Yeah.
The middle diagnoses are your main hospice diagnoses, right? Your outside wheel is your supporting. So if you have a main diagnosis in that middle wheel, and then 2 or more of the outside wheel, probably a good indicator that the talk about hospice needs to happen, and that maybe even depending on like what your wound status is, your medication changes, your infection rate is, you might actually qualify for hospice with 2 and that middle diagnosis. So we use that. I actually have for my advanced clinical people, I actually have a questionnaire. It's 12 questions, again, clinical side of it. It's giving me percentage of weight loss, it's giving me all these different things that I look for. If I have any nurses, retired nurses like my grandma, I can give it to her and be like, Grandma, okay. You're looking at somebody, if you have to mark yes for any one of these, they're probably hospice appropriate. But so that eligibility wheel is my basic one that I give out to people, because you could really look at somebody maybe you're caregiving for and go, okay, well, they have a diagnosis of dementia or heart failure, heart disease, and increased falls. There's that stupid little wound on the back, won't go away. And they've been to the ER like 3 times this year. Okay, it's probably time. I actually had this really nice presentation, but I didn't know if Corey was gonna have her, I actually do have a lot of resources with the NHPCO, National Hospice Association, with different things of how to have conversations, and that there's no better time to talk about hospice than now. You are healthy, you are in your right mind, it is time to talk about what you want your end of life to look like. Because one of the biggest things, and again, I talk to families on a daily basis. One of the biggest struggles family members have is their mom, their dad is laying in bed, nonverbal, not able to communicate, not able to tell them what they want to do, and that child has to make that decision for them.
Yes.
And the guilt that comes with that. Making sure you're making that right decision. I just had to have a conversation with a son yesterday, and he was so against hospice. It wasn't until they got a family friend involved who happens to be a lawyer, and he's like, no. There's no taking her home without hospice. She needs hospice. So he needed that direction, though, from a family friend who happened to be a really good friend to her, to then feel comfortable to make the decision that he wants hospice for his mom. You know, so have the conversations. It's like my biggest, have the conversations. My husband knows what I want, you know?
Is this supposed to be a legal thing, or can you just write it out or tell your kids or your husband or?
Oh, it could be as simple as signing a
The
piece.
5 wishes, do you have that?
We don't do the 5. Yeah, we don't do the 5 wishes anymore.
You can just write it out
I
and sign
mean,
it.
yeah. There's nothing wrong with that. With
Just so
writing
it's
out.
known.
Yeah.
Okay.
And
And
like
those
Christina was saying, it makes the process so
much easier.
for everybody. I had a conversation with a family, there were 7 children.
Yes.
Nobody
Oh,
thinks
boy.
All of them had their own opinion.
Yep.
Sure.
And to get to the root of what that patient truly wanted was an excessive amount of time that we could have been just providing the care that she ultimately wanted. So again, talk.
Yes.
Just let somebody know this is what I want. And
What
you
she
can
wants.
use this document. You know, use this document that Christina has with the wheel and say, okay, if this, and this are going on, put me on hospice,
I'm done.
right? So that they know.
So something that's nice, so I'll put in here, is the benefits to earlier admission to hospice. Again, most people think hospice is, I'm dying tomorrow, I'm dying the next week, whatever it may be.
No, and it's not.
No,
No.
it's not.
I admit patients all the time who maybe have a cancer diagnosis. They don't want treatment. I have one, she is ambulatory. She is helping take care of her husband who has dementia. She has a diagnosis of cancer, Mets to the bone. So we know that is going to ultimately, it's going to take her life. The last time she did a course of chemo treatment, she ended up getting a severe case of shingles. And then ended up with paralysis on her left side. So she now knows chemo is not going to be the best bet for her going forward. She does not have a DNR in place, which is totally fine. You don't have to have a DNR in place to be on hospice. Our staff is very much able to help work through that process with patients, loved ones, to help them kind of guide them in the right direction of putting a DNR in place. Because if you think about it, pains me when I think about I don't know if my grandma's got a DNR or not, but she is a tiny frail woman, and to know that someone would be pounding on her chest and breaking every single bit of her rib, it mortifies me. So, we have those conversations though with families to let them know kind of what that process looks like and why it's important to have a DNR in place. Hospice, again, is not the end all be all. At any point in time, we have residents that will what we refer to as revoke off services, and they now at this point maybe got a new diagnosis of something, and they're like, no, there's this miracle drug, we're gonna go get that. We want to go and try to get better, which is fine. We then at that point will actually make the referral right back to home health.
Come back to us.
Home health will step in. They'll try to get some therapy in there, nursing in there, whatever it may be, to help then get them stronger. So we work very much hand in hand, because we do have patients who graduate off our services. When you have hospice in your home, say you're going to take your loved one home, they want hospice. And I'll go back to the hospitals from what I'm hearing. Hospital turnaround is about 3 to 4 days. So you have your loved one in the hospital, their social worker saying that they're going to go home, you want hospice, that's great. Hospital systems are taking 3 to 4 days to come to the home to even admit the person onto services. The staffing shortage is astronomical. It's terrible what's going on right now in this world with healthcare workers. I will tell you, I love working in my community, I do same day bedside informationals. My aunt calls me and says, hey, I got a friend in the hospital. She's at this hospital, this room. They want to talk about hospice. What time can you meet? If it's going to depend on where I'm at. If I'm in the north side of the city, give me an hour and a half, I'll be there. If I'm at my house, I'll be there in 20 minutes.
So that's the go-to?
I'm sorry?
So Beth is the go-to?
No, I'm just using my aunt because she's sitting right here.
Just call her.
We're gonna put you in.
No, what are you talking about? My mom gives out my personal cell phone number. I am very local in the sense of I service my community. I live here. This is my home. I do same day bedside informationals. I will talk to families. My kids are wonderful. God bless their hearts. But I'll do informationals on the phone. You know, I sat and talked to a family who I didn't even have clinical paperwork on, and did an informational with the daughter for 2.5 hours while my son took a nap on a Saturday. So, you know,
Lucky you.
lucky me.
365 days a year.
Yeah, we are 365. So, you know, it's different again when you're getting into someone who is not a hospital system. You're going to get kind of a better customer service in return. I will do same day admissions. My companies, we are very much, we stand by. You send me, again, the hospital sends me everything I need clinically in regards to paperwork, orders, all of that stuff. Families on board to meet, to do the admission. We can be in someone's home within 3 hours. I will have a nurse in the home within 3 hours. I will have medical equipment. So your DME, hospital bed, Hoyer lift, bedside commode, whatever it may be, in the home within 4 hours. You're not going to get that with, again, your hospital systems.
And just so you
Is
know,
this
that's how
all
it should.
nationwide?
Yeah.
So my sister-in-law.
And just so you guys know, that should be the standard.
That should be the standard.
Okay, so that's the standard that you should hold your provider to.
Yep.
When you're assessing for hospice. Again, hospice is a highly emotional,
It's very,
very stressful
Very now.
period. So to sit around and wait 3-4 days for your support to show up can be devastating.
Yep.
Right? This needs to happen today. We're on board. Let's get what we need on board. That should be the standard in which you hold somebody to, especially when they're going to be caring for you or your loved one at that point in their life.
well, and ultimately, hospice is not, yes, we are patient specific, but we're there for the family. You know, the nurse is there, again, different from home health, which is typically 2 to 3 times a week with a nurse maybe visiting. Hospice, we can do the daily visits. Depending on what that patient needs, we actually will change around our care plans to make sure we are servicing that patient. We do nurses. So if you have a loved one who's at the home on hospice, you're looking at a nurse who's going to come in, say the patient's stable, right? They're not actively dying. Their pain control is stable. You're looking at a nurse typically 2 to 3 times a week, again, depending on where they're at a minimum 2 times a week. That is a nurse that is coming in, that's assessing patient's skin. That's a nurse coming in, making sure they're assessing a patient's pain. That is a nurse that is going to make sure they're laying eyes on that person. Making sure they are comfortable for whatever life they have left. You then, at that point, also have an Aide, so a CNA, Certified Nursing Assistant, who comes in, who is there to make sure that they are dedicating all of their time to the patient. They don't do laundry, they don't make food, like, that's different. They are there to help, again, clean up the patient themselves. You will also have a non-denominational chaplain that comes in. You know, so I actually just learned they also were Jewish accredited. So they also can kind of, we have priests on service, like on at our access, we now have rabbis. We have kind of everything within regards to the different services of worship. So nurse 2 to 3 times a week, aide 2 times a week, chaplain is once a month typically, or as needed. So obviously it's different towards end of life, all of that stuff. And then social workers once a month or as needed. So you might have some very difficult family dynamics that maybe the social worker needs to be in there once a week. You know, everybody is different in regards to, we have some patients that say no to the chaplain, no to the social worker. They have everything in order, all of that stuff. So then those are just kind of, we don't put them in the care plan. They're there if necessary, but they could just be on standby if something happens. So again, you're looking at home health, 30, 40-minute visit, twice a week maybe, and then again, short-term benefit. Hospice, it's a longer-term benefit. We have patients that are on services because again, they meet the criteria, and after a certain time frame, we don't have to report anymore to Medicare. We just keep them on services. If again, they qualify. We graduated someone off services, I think they were on for like 3 years. Graduated them off services.
And I want to interject there. It's
Is it
not
got better?
Yeah, it's not
She gained weight. She had dementia. She was on because she was like, wasting away to nothing. She was down to like 79 pounds. We ended up discharging her after 3 years. Her dementia obviously was still there, but she was like 110 pounds.
So sometimes
She's
what
stable.
you'll see, especially during the pandemic, this happened quite a bit, where we would have a COVID positive patient who had deteriorated to the point where they qualified for hospice, and hospice came in and gave them all that extra love, care, and support, right? That's the most care that you're gonna be able to get in the home is under hospice.
Yep.
Right? So they got all this extra care and attention, and they improved, right? So sometimes the patient is declining, we're like, oh, it's hospice, then they bring in hospice, and all of a sudden you'll see this bounce back. Right? Right, because they just needed that really focused, intense care that hospice can offer to kind of turn the corner and head back to a more positive direction. So again, she'll graduate them back to home health, which is fine. So sorry. Just
No,
wanna let you
you're
know.
good.
Yeah.
No, because that was a great example. Great example.
So
Because we saw a lot of that. A lot of it. Where families were even shocked that they even made it out of the hospital and home. You know? So it's very, oh, go ahead.
So with hospice care, with hospice care, if someone's living by themselves,
I'm going to tell you. I actually just came across that one. It is very hard. Very hard. Typically at that point, like I just came across one where she was living by herself. She needed hospice. There was no one, not even a neighbor who could come in and try to help her. It's not safe for someone to be in their home. We would, honestly, so like within regards to that patient, we were actually able to work with a local skilled nursing facility and able to get her into a nursing home. It's not ideal, but there's nothing else to do because it's not safe for someone to be in their home, because what happens if that person passes? Our nurse isn't scheduled for maybe not even the next day, maybe the day after. Right. It's not safe. You know, we work a lot with the different nursing homes in the area, and we have relationships with them where we have emergent cases where we had one over the winter. The son was the primary caregiver, lived in the home with his mother. He ended up being rushed to the emergency room and having to be admitted.
Ooh.
So our staff went and sat with her until we could get an ambulance set up and get approval from one of the nursing homes we work with to get an emergency respite.
Right, yes.
Yep.
So we don't want that, nor does anybody else want that person to be in their home by themselves. So
do you have somebody that you're thinking of?
well, I was just wondering if insurance picks up any kind of other care.
So
typically, so if you're looking at so when someone is on hospice, okay, well, this is gonna open up the wormhole here, okay? So traditional Medicare covers hospice at 100%. 100%. That is all nursing, everything. Now, good news for you. Ready? My Medicare replacement.
20%.
Medicare. So so Medicare replacement policies revert back to Medicare being primary. So you will be covered at 100%
Oh, great. When
on
I'm
hospice.
There's some money there.
Hey,
We-
nothing.
I got good news on that one.
Yeah.
Now, your traditional, obviously under 65 commercial insurances, they do some do have hospice benefits and some don't. So I'll just be honest, some don't. So, but good news for all my 65 and olders who have Medicare or Medicare replacement, it does always revert back to Medicare. So that is your nursing is covered. So that's if you're obviously in your home, everything is covered. That is your DME, so any kind of equipment that comes with your hospice diagnosis, a bed, bedside commode, your briefs, if you need briefs, any incontinence supplies, things like that, it all is covered. Wound care, dressing changes, all of that stuff is covered. If you are in a nursing home, so say you're in a nursing home, long-term there, and you don't have Medicaid, again, wormhole, I'm sorry. Traditionally, people who are in nursing homes will ultimately spend down their money, and then they'll go to Medicaid. They'll apply for Medicaid. If someone does not have Medicaid, then there's the room and board that has to be paid for. So remember that 20% we were talking about? It's pretty much what it is. It's like that 20%. There's something.
So if, for your instance, if that person was on hospice, needed to transfer into a facility, the patient would be responsible for the room and board component.
Yep.
Not for any of the clinical care, because the clinical care would fall under the hospice benefit. So our team would be coming into the nursing home and providing the clinical support. They would just have to pay for
The room and board.
But they couldn't stay in their home and get outside 24 hours care.
They
absolutely
could.
Yeah,
Oh, yes, they
absolutely,
could.
Absolutely.
But can I tell you something? Do you know the cost of 24-hour care?
Yeah.
24-hour care giving is very
You're looking
What I
at-
meant was they're covered.
Oh.
No, that is all private pay,
All
and you're
private
looking at roughly anywhere from $30 to $35 an hour. Obviously, it's a little cheap. Well, no, because 24-hour care is hard to find.
Yeah.
Because those are 12-hour shifts
There
typically.
are a few agencies that I work with who do specific live-in, right?
Yeah.
Live-in caregivers where they actually move into the home permanently. But again, that is an
Pricey.
expensive benefit to have, and that will always fall out of pocket.
So unless you have long-term care insurance. to cover-
But long-term care insurance actually only covers a certain amount of money each day.
Yep.
You're looking at roughly about $150 a day.
So I guess, let's walk through this scenario, because I would like to get clarity on it for myself. When you have a patient actively on hospice, Medicare recipient, move into a nursing facility, do they get their Medicare days?
No.
They don't.
No.
Okay.
So if you have someone who is going into a nursing home, we try to help offset some of the costs by doing what's referred to as a 5-day respite. So we, the hospice company, will pay the facility for 5 days worth of care. Okay? You're looking at roughly anywhere from $250 to $300 a day that we are paying that facility, that we are saving our clients. With that being said, we're typically asking for a favor from that nursing home, asking for them to take someone public aid pending, no application even filed, which financially is a huge risk for these facilities. But again, they value our partnership and we value their partnership. It's a give-take relationship. So we're willing to take that cost on for 5 days as long as they're willing to help us by helping these families apply for public aid.
So I'll tell you, I just had to do this with my grandmother, rest her soul. She passed away a couple weeks ago. What we had to do was start the hospice. We knew that she couldn't stay at the home. We weren't going to pay for a private caregiver, that we needed to move her into a facility, right? So we liquidated enough cash for the first 6 weeks within the community that she was going to be going into, and then liquidated the house so that we had a chunk of liquid cash that would pay the room and board for as long as that she needed it.
That's legal to do?
Yeah, you have to liquidate.
You have to.
So what will happen is any assets, so when you have somebody who moves in that's gonna eventually, when we're making that move, we know that's the last move, right? We're on hospice, this is the last place that she will be living. You liquidate everything, and then that money sits in an account to pay for that cost, that room and board cost. once you meet the threshold of draining that account, where you can apply for Medicaid, then you apply for Medicaid, which you would have a Medicaid pending status, which is
So-
what Christina's talking about.
$2,000.
Yes.
Yes.
So
Yeah.
part of all of the support that you get, and I will tell you, I've had to do a lot of education with my social worker because she knows nothing about how that skilled
Financial
nursing, that financial side of skilled nursing works. I've had to do a lot of education because I did admissions for 6 years in a nursing home. I know it. She didn't know it. So I've had to help her with education and helping the families navigate that. But that's part of our job, is to help these families navigate that system, because it's a lot. It's a lot. You know?
If you have any questions though, we'll give you our cards. Like I said, if
100%, yeah.
There's
I was
stuff.
gonna say, do you guys have business cards? 'Cause
Yeah,
I'm
of
already
course.
sold on this
Yeah.
program.
You're gonna be my new girl, yeah?
Like I told you.
I'm getting my money's worth.
Yeah.
I'll tell you right
And before Christina wraps, I always tell our families, whether you're on service with us or
call
not,
us.
we are your advocates, okay? So I've worked with families now for several years, where they don't need anything from me, but they have questions, right? They need a resource. Use us for that. Use us as your backbone when you're navigating the next steps in your life, or you're navigating the next steps for your parents. We're here. Whether you're under our care or not is irrelevant.
And I don't know what you're talking about. You just go have a conversation with my mom, and she'll give you my cell phone number.
Yeah.
She'll call me and be like, "Hey, Chris, I gave out your number to so and so," and I go, "Do I know them?
No,
Do I know them? Like, okay, what?
Do you guys have
what do
any,
we?"
do you have any questions for Christina specifically about hospice?
I have a question for both of you. How much do your services cost?
There you go.
So again, mine is, if you have Medicare, you have Medicare replacement, you have Medicaid, you're covered.
Okay.
And Medicare is covered 100%. Most of your replacement plans will be 100%. Unfortunately, your neighbor has a plan that covers 80%. So it just depends on, if you have a replacement plan, what the home health benefit is. But if you're Medicare,
It comes out of there.
Yep. So each Medicare replacement plan or Medicare Advantage plan has a home health benefit. Okay, so that's just built in. It's just whether or not it's gonna mirror Medicare and cover 100%, or is it 90%, or do you have to meet a deductible and then it's covered, or do you have a copay of 20%? So it just depends on your plan. But I will tell you this, we do not take on patients if you're going to absorb more than 50% of cost, because it is very expensive, okay? So we'll let you know, obviously, what your benefits are. If you get an order from your doctor and you're like, I don't know what this means, what are my costs, if any, just call me. I'll run your benefits. We always call if there's gonna be anything other than 100%, just so that you're aware if there's any financial responsibility on your part. But again, typically, it's gonna look like what you would pay for a doctor's visit, right? Or to go to an outpatient lab, or outpatient clinic for therapy. So anywhere from $30 to $50 is typically what we see if you do not have 100% coverage.
Yeah, like the form I signed last night for my physical therapy said you have a $25 copay until you meet $2,000, and I was like, whatever, just send me the bill. I'll take care of it.
Yeah. And then again, if you have any other additional questions, I'm sorry, I don't know your name. Judy. I
You
can
guys
help.
are doing great.
Okay.
I get more information from you than all the months I spent with my husband,
Aw.
back and forth.
I'm sorry to hear
I'm still
that.
getting phone calls, and bills and.
I know.
Yeah, I'm sorry to hear that. And again, like I said, even if you guys aren't on care with us, even if your loved one isn't on care with us, if you go to the hospital and you wanna make sure every T is crossed and every I is dotted, call one of us. We'll call your case manager at the hospital and be like, all right, hey, Susan called me. I know she's in room 202. I just wanna make sure this is what's
So
happening.
here's the nice part. I, as hospice, can get in hospitals no problems. Home health's a little harder to get in, but I can go to hospitals.
So we
And-
can just be your checkmate,
Yeah.
make sure you're being safeguarded, that the right things are happening, that the
Yep.
right decisions are being made, that you're understanding what they're telling you is happening.
That's the thing.
Right, they talk and you're just like, okay, and then they run out of the room,
Yeah.
right?
That are talking to you, the social workers.
Yeah.
I think you understand it, and then.
Then you get home and you're like, oh, shoot.
Yeah.
Right, and you're overwhelmed to begin with.
I do want to say, I have Sandy back there going like this. So what we'll do is, Principal Sandy back there is saying, wrap it up. We can talk. We can talk.
Let me grab my card.
Yeah, Principal Sandy back there. We go back to how I know her. No, we appreciate you guys. We enjoy talking. Like this is what we love to do, is to educate as much as possible. So, Facebook. If you guys have any questions, just send me a message. I'll when the video's up, I'll put my email on there for you guys.
I just get one more question.
Yes, ma'am.
In regards to billing, you're billing Medicare directly and the supplemental insurance.
We don't even deal with supplemental. We just do your primary.
Hospice is all gonna be covered under
Yeah,
Medicare.
it's all gonna be covered under your, yeah.
And so is home health.
Oh, okay.
The only time your supplement, you're welcome.
Yeah, the only time your
The only time
supplement
your
comes
supplement
in
will
play.
kick in is in rehab,
Nursing
or,
homes.
or long-term stay at nursing facility.
All right, good.
Goodbye. You're good.
Thank you. May you have your card?
Yeah, you can